not yet drunk last night. And so this morning, our first session is endoscopic surgery. What is the latest? So I'm Dr. Simon Wong from Hong Kong, and co-chair with me is Dr. Ken Noy from Australia, and also Dr. Ray Sarmiento. But Ray has some business to take care, so he will be late. So here comes to our sections. So we have four distinguished speakers today. And may I introduce the first speaker? Because of the COVID again, he cannot come, so we will have his video. He is Manu Gabriel Nato. I think a lot of us know him. Manu is a brilliant endoscopist surgeon, and now he is the clinical professor of gastroenterology and surgery at St. Mitt's University, work with in India. And also he's the affiliated professor of surgery at ABC College Medicine at Sapporo, Brazil. And also the head of endoscopy, bariatric endoscopy service at Mohit, working with Mohit in India. So without further ado, maybe we can share the video now, and let's enjoy.
Greetings, Manuel Galvão Neto. It's a pleasure and honor to be among you in IFSO APC Manila of this year. And with no further delay, I'm gonna share my screen. And my topic today will be about sleeve gastrectomy leaks and fistulas. And we're trying to guide you through this whole issue here. So this is Mohit Bandari and Mohawk Bariatric Center, where I work with you. I'm proud of. That's my disclosures, our collective disclosures. I offer you to judge. And sleeve gastrectomy leaks. What is the state of art of endoscopic treatment and that? So the pathophysiology we now know very well is all about pressure. And when you create a sleeve gastrectomy, the stomach environment that is low pressure, high compliance goes to high pressure, low compliance, and it forces the leak to be chronic. As you can see here, this high resolution manometry. So just check below the inferior color line. You're going to see before and after how we pressurize the stomach, and even our own data is from our center on Mohawk also shows us that we pressurize the stomach when doing sleeve gastrectomy. And this tends to keep the leak chronic on that. The surgical options we have is that when you have the acute leak, you have to drain, you have to wash, it's suturing or not, and then the patient sent to us. In the chronic leaks, there is surgical options they are very effective, converting to Huawei gastric bypasses, esophagojejunostomy, and total gastrectomy. But let's see this review from the French for the French school. You see that it comes with a price. So the time, conversion rate, and even leaks, they are treated leak, and mortality can go on that. So in terms of endoscopic options, very good news. We have a lot of options. Every single author claims a very high resolution of those leaks. The bad news is every single one claims the same. So there was no clear unbiased algorithm on that. Mostly of them they use to treat this classification raised from the international sleeve consensus that we take part. That is acute, early, late, and chronic. So let's start with stents, most used for acute leaks. So the stents have the mission of occluding the hole and take down the pressure at its spans over the incisura angularis. How it goes, so let's see this meta-analysis done by São Paulo University, 72% of success rate using any kind of stents, non-specialized stents on that. The leak, as you can see here, comes from the proximal part, 94%. And the timing to put the stent is acute and early, so as said before. Bad news, 1.4 stents per patient, so be prepared to rearrange the stent during that, and the migration rate is almost 30% on that. So what meta-analysis escapes is the perforation case, bleedings, and deaths report, so we're going to explore a little bit more. So what if we use customized stents, a bariatric stent on that? We can go, and as we publish here, up to 100% of success rate in the tertiary center, and just read the small letters. The patient is gonna feel very bad for at least 1 week with symptoms like vomiting, pain, and quite some of them that. And we could reduce with this specific stent the migration rate to 16%. But this is a tertiary center dedicated to that. So look at this paper that we produce using more sophisticated stents, the Korean ones, and 84% success rate, as you can see here. Big leak, stent in place, no leak after that, but small letters. Yes, from letter A, you're seeing the thorax or perforation. B and C, the stents that dislodged require an operation. D is a contained perforation. E is a distal ulcer, and F is a submucosal abscess on that. So there is come with a price on that, and we can follow even more scary ones by the French school of 5 patients that get to aortic injuries even with death. So that's have to be wait and follow very careful if you want a good results and you don't want complications. Following that is also from the French school comes the the double pigtail stent, pigtail stent, sorry for that, and I'll guide you to that how it is. So imagine that we're seeing here is a model of a leak. You can see the leak on the upper part, you have the stenosis on the distal part, and then you put a stent. And this pigtail, one part goes inside the cavity, the other part goes inside the lumen. So it's an anatomical drainage. You remove the external drain, and most of the times it goes very well. So look at the systematic review here with 84% success rate. 681 patients, most of them coming from France. Now it's spreading a little bit more, and complication rate is less than 30%, and less severe. And again, 84.42% of success on that. And the EVAC is a new thing and becoming more and more popular. It was designed for septic disasters on the mediastinum and on the lower rectum, and now is used for the sleeve leaks. So the experience is very limited on that. It for sure it can use, but at the cost of more days in the hospital. Look at this paper, 50 days in the hospital, 10 procedures per patient. It evolves, so not using the sponge, using an alternative that started in Brazil, now is spreading more. So use a 4x4 gauze and a plastic dressing, multi-perforated over that. You can even pass another probe or another tube inside to feed the patient. And it will be less than the hospital, less endoscopic procedure, but still kind of cumbersome and a little bit difficult for the patient. And what nobody tells you, that everybody says good things about it, but there is reports of bleeding and deaths from arterial fistula because the suction is very powerful from that. Specifically in sleeve gastrectomy, this suction, if it's intercavitary, it can suck up spleen and splenic artery and things like that. Septotomy was developed by us in Brazil, and it's for chronic leaks. So if you ever see a sleeve leak, you see like that, you have a septum separating the stomach from the cavity, and this septum is made of the sleeve staple line on that. So the idea is you cut it, you level that the cavity, then you aggressively dilate it with pneumatic dilation, taking down the pressure, rerouting the path of the food, it closes by itself. So we published quite some papers on that. It's reproducible, so check this one coming very recently, coming from America, United States. So you can see here what they use for chronic leaks, latent chronics, and good success rate on those small series of patients on that. And endosuturing, why not suture the leak? Because not going to work because you don't address the pressure. But what you can do, and it's really effective, is to suture the stent in place, taking down the possibility of the heels, the Achilles heels, that is the migration of the stent. And it's effective, as you can see here. So this over the scope clips, there is a lot of hype on that. People start using that. Initial results are good, but just check this. This recent paper with low efficacy on 26 patients that had used this over the scope clip with different alone and with different endoscope techniques. 11 patients needs esophageal jejunostomy or total gastrectomy, so it's not really that effective as some people thought on the beginning. And also we have these occluders, cardiac occluders that being recently used basically by one author, and he trained quite some centers on that. This is Roberto Batista from Venezuela, but for chronic leads, you can see here in sleeve, very effective and very expensive to do that. So there is all of them. And also, if you aim to take down the pressure, don't forget the achalasia balloon dilation that we described for the first time in 2010 and have been used widely to take down the pressure. So this kind of achalasia balloon dilation, they're very aggressive. You can see here on the endoscopy on the upper side, on the radiology on the upper side, how effective they can be in taking down the waist, dilating the whole sleeve, taking down the pressure. So it's just to show you what we just have in our armamentarium, the stents occlude the hole, take down the pressure, uh, double pigtail, equalize the pressure, balloon dilation, take down the pressure, occluders for chronic leaks and things like that. So in the subjective comparison, because there's no unbiased algorithm on the literature, for acute and early, stents, pigtail, evac. Later in chronic, septotum, pigtails, occluders, and evac. High tech, high price, stents and occluders. Low tech, lower price, pigtails, septum, and evac, depending on how many days the patient is going to be in the hospital. And if you are in the private, it will add a lot of cost. So easier for the patient, pigtails, occluders, and septotomy, you put it in, patient can go home much easier. Harder for the patient, stents, because it is hard to adapt, evac, because the patient is going to be adapted to the suction machine. Brief hospital stays, pigtails, stents, occluders, and septotomy. Longer hospital stay, definitely the evac. So, endoluminal treatments of sleeve leaks, they are complementary, they do not compete. So you can use one after the other, or if intention to optimize the treatment. There's no such thing that the best one, that's not proven yet. Sleeve leaks, they are all complex. Look for strictures and kinks. There is a clear need for unbiased algorithm. Good news, most of the treatments can go up to 80 or more percent of a success rate. Going the other complication, that is the stenosis. Stenosis are very sneaky because to be a stenosis by endoscopy, the scope should not pass, but on the sleeve it will pass. What you have here is extra deviation, tortuosity that will increase the pressure and patient cannot come. Most of the patient comes to us about the third or fourth month because they cannot tolerate solid foods. So what we can offer, pneumatic dilation, strict droplet and stents. So as we had described, pneumatic dilation, they are very effective. Again, just take a look at that. What is the literature? And you can see here on this video we did in IRCAD with Giovanna Peretta and Gianfranco Donatelli. So just take a look as we pump up. You can see here how we stretch the body of the sleeve, how pale it is, and we are going to 20 plus psi on that. And you can see here how effective it is. And we have this data with EndoFlip showing us before on the left and after that it's really effective when we dilate to that. Papers, so we have this small series, 17 patients that we end up to 80%, 88% success rate with the sleeve, with dilation alone. And we've add stents after the dilation that the ones who are not responding can get 17% more. So how about this paper, 35 patients, that the rate, that's for French, the rate of healing, they are not that high. It is because they got this patient very, very late. So ending my presentation on the 12 minutes allotted, we have this review that we did with Victor Ottoni in Brazil, that we can see here that endoscopic treatment, it wins over surgical and over and among the endoscopic treatments itself. So thank you very much for watching, and I hope we can see each other on the discussion time.
Yeah, I don't think he's here, but Mohit can probably answer all the question later, I think. Yeah. I don't think next person needs introduction. When we design the schedule, I think we noticed Mohit is the highest volume bariatric surgeon, and don't know why he find time to do all the balloon as well. So you're gonna tell us how the evolution of that. Hopefully, we can hear from them. Thank you very much. Thank you.
Can I have a mic, please? Yeah. Okay, so thank you, Simon. Thank you, Ken. Can I have my presentation on the screen, please? Okay, so good morning, everybody. It's an honor to present something new and something very innovative to this audience at the IFSO APC 2022. This is my case mix. As you can see that we do a lot of bariatric endoscopy stuff also. We have done close to 900 endoscopic sleeves. So this is just the data from my center, but we operate at 5 different centers across the country. That's my university. And you already know that I work with Professor Gelwao, so anyone who's interested in the training of bariatric endoscopy can come and be with us for a day. Every first 10 days of the month, Manuel is at Indore. Why I am here to talk about a non-surgical device which even does not require an endoscopy. There's a brief history. So, we started this bariatric program in 2010, and you can see that as we are progressing forward, we adopted with the time, because the time has changed. And now we have come to bariatric endoscopy, to endoscopic sleeve, and then finally to something which is non-endoscopy. So as a surgeon audience here, it's more important to develop the perspective as to why we shifted to, not completely, but around 10 to 15% of our practice to a non-surgical, non-endoscopy method. These are the number of bariatric procedures we have been discussing about since last 3 days, 2 days in the conference, and we all keep on debating upon which is better procedure. But this is a very important slide, that bariatric surgery is the strongest tool available against obesity and type 2 diabetes. Professor Cummings is here. He can pick up more than these meta-analysis. I know 122 meta-analysis and 45 randomized controlled trials, which says that it's the strongest procedure, but then why there is an existential question? Or is that a relevant question which we ask ourselves, that are we able to treat each and everybody in the hall who deserves the treatment for their morbid obesity? So this is very important, that we are dealing with a chronic disease. It's a very recalcitrant disease, and it has immense power to fight back, just like malignancies. So at best, any treatment you give, it may be medical management or surgical management or endoscopic management, all of them are at best palliative treatments. They are not going to cause a complete cure. So considering that fact, it humbles us today that despite doing 18,000, 20,000 bariatric procedures, I could at least soul search and find that I have a need of a device where it does not involve surgery or endoscopy. Now, why I need that? Because we all know just 1% of individuals would come up for a bariatric surgery, and most of them would refuse to disclose it. And when asked during studies that if there was a non-surgical, non-endoscopic option available without involving anesthesia, they said, yes, we would have gone for it. So treatment at best, no cure, just a palliation. So what do we need? We need, and I realized that I needed something non-surgical. I needed something which does not involve anesthesia. So no endoscopy, because we know that patients who have to do endoscopy in our setting at least take sedation or partial general anesthesia. No hospital admission, which means that the procedure can be done on an outpatient basis, like a patient coming in and going out in 15, 20 minutes. No hospital visits are required, somewhere where we can go for a virtual consultations and do not call the patients to the hospital. In short, a COVID-free environment. And when I thought about this in 2018, I started to discuss with Manuel that is there a modality available on this earth which fulfills all this criteria? And if there is such a modality available on this earth, it's going to change my practice. Because I don't want surgery, I don't want endoscopy. I want something which can be done on an outpatient basis, even in a non-hospital setting, where I can just call the patient, bring him in, do the procedure, send him home. He said there is only one thing available at this point of time, and as the director of bariatric endoscopy services and your consultant, I would say go for a procedure-less balloon. I said, what's that? He said, it's just a capsule, and the capsule is like a vegan capsule. You swallow it, or ask your patient to come in outpatient clinic and swallow it. It has a thin catheter attached to it, can be converted to a balloon like that in just 5 to 8 minutes, send the patient home. I said, no, it can't be that simple. It said, it is. And then we discussed about Allurion. So that's how it changed my practice. This is a swallowable vegan capsule, which you can ask your patient to swallow in the outpatient clinic. It does not require any surgery, any endoscopy, or anesthesia. It's a 15 minutes procedure. The concept is that the patient will swallow this capsule, and this capsule has a very nice, this is a vegan capsule, has a very nice folded balloon inside it. You can see here, and there's a thin catheter here through which the filling of this balloon can be done, and then once the filling is done, you can detach this catheter and send the patient home. It's that simple. So this is the device. You have to swallow it. It's a 15 minutes of outpatient procedure. This balloon is pretty soft as compared to all different other balloons available because it's polyurethane, not silicone. And it has that nice propensity of passing through your small bowel into the large bowel, into the motions, without causing any damage to the intestinal mucosa. So obviously it has to be very soft. It disappears from the body through your feces in around 4 to 6 months period. Now why and how that happens, I'll just give you a brief. So there is a release valve which is made from a thin film with a hole, which is closed shut by a degradable filament. Now this degradable filament is the life of the Allurion balloon. This filament has a life of 4 months. After 4 months it's going to degrade, releasing the distilled water out, and this capsule is going to pass into the motion. So this innovative technology is devised by the Allurion, and that's how it happens. It's a very simple procedure. The patient gonna come to your clinic. So this is a very short video. I'm gonna, I don't know, I don't have the, so let me take you through the video. Okay, so the patient walks inside your clinic. It's as simple as that. And you explain him about the Allurion program, how he has to swallow the capsule, and that's simple. It takes 5 to 8 minutes for the patient to understand that. Ask him to wear a gown because when he drinks water, he does not spill it. There are 2 techniques to this. First, the patient can swallow it himself. That's simple. If not, you can use a catheter or a stillet here to put through this catheter, through this thin catheter, and then push it through the patient. So that's also another good technique. I usually use the catheter, the stillet-based technique, pardon me, to push this capsule through the patient because I feel that's very simple. I don't leave it to the patient to swallow a capsule. I just do it myself. So you can see that he is drinking water, and I am gently advancing the catheter with a stillet inside it, which comes as a part of the kit. So that's it. I take an X-ray, check whether the capsule is in place, and I demonstrate it to the patient. Once that is done, I would then consider the filling of this particular balloon, which takes 2 to 5 minutes. Around 550 ml of distilled water is filled inside the capsule to be converted into a balloon like this. And then we will take another X-ray once that is done, and then we will remove the catheter very simply. So you can see, we explain the patient and the catheter is removed like that. So this is a very simple procedure. We have been doing this, now in huge numbers. And this procedure is as simple as what I have demonstrated here. That's it, as I said. In fact, most of the patients will do it in a group, just like this. So this is, I can put 5, 7, 8 patients in my clinic, use the stillet technique to put these capsules inside one by one. And we have done maximum 10, 15, 20 patients also sitting all together. I have 5 different clinics across the country, so I keep on traveling, keep on operating, doing surgeries, and in the meantime, between 2 procedures, I do these swallowable capsules at these clinics. So at one time, we have done 15, you can do 20. You need to have a radiologist ready in the X-ray room. You can go inside. One patient gets the capsule, comes out, another patient goes in. So yeah, it's simple, and that saves the time. I've already explained about how the valve opens. It's the life of Allurion balloon. It's a degradable filament. I don't know about the composition of the filament. Let's talk about the study. So what weight loss do you expect? It's the same like any other balloon you would have used. I've used 5 different balloons in my own practice, starting from 2008, before even I was doing bariatric procedures. And most of them would give me 14 to 10 to 15% of total weight loss. It's the same with Allurion. It's not different. This is a very important trial which they did. It's an international multi-center registry. The conclusion is, again, 14% of total weight loss at 4 months, which is what they claim. The most common complication, as they reported here, would be intolerance to this balloon, which would require endoscopic removal. Something I can say here is that I've been using the balloons. My rate of balloon removal with balloons that are put by endoscopy is around 50%. Here it's 0.01%. So if we put 1,000 balloons, we remove every one of them. So it's pretty less, I mean, as compared to the old balloons. I mean, negligible as compared to the old generation balloons we're using. The results are fantastic. It's safe. It's effective. Again, about the sequential balloon. So most patients ask us, once the balloon is out in the motion, can we use sequential therapy? I do it in my practice very commonly. We put the first balloon in after 6 months, once this balloon is out, because usually it comes out by 4 months, but we wait until the 6 months so that you're very sure of the balloon coming out, do an X-ray or any radiology we are comfortable with, and then put another one. And if you see the data, and we're going to present our own data, but the first balloon causes 14%, and the second balloon another 10%, taking it to 22%. So the maximum is 40.9%. This depends upon every other individual, but the message is sequential balloon therapy or sequential capsule is also causing very good amount of weight loss. And sequential balloon weight loss approaches what can be achieved with bariatric surgery at 1 year when they saw the maximum weight loss. The long-term weight loss maintenance, this is the question a lot of patients ask us. What after the balloon is out? Because this is a forced behavioral adaptation, or it is something where the patient tries to learn the feeling of early satiety. Most of these studies would show that at 1 year, even after the balloon is out, they maintain their weight in tune of 72, 73, 93, 95%. So this study by Lenka et al. Shows 95%. My own experience, I would present, we have been an 8 months old program, but yes, it matches the experience they published. Somewhere around between 75 to 90% of this weight is maintained. Again, as you can see, that they have a virtual follow-up. So the beauty or the ethics of the entire company is that as a bariatric surgeon, I never gave a weighing machine to my patients to judge my bariatric surgery or the efficacy of my surgery, but the company gives a weighing machine and a health tracker to the patient with a virtual care suite where patient can see his weight every day, can monitor the number of steps he walks, and that data through the app comes directly to the service provider or to the doctor, and then they can raise the red flags. Not only that, now they incorporated the artificial intelligence to the entire virtual care suite. So if there are any red flags, the patient not losing weight, we would come to know immediately. In bariatric surgery, we usually come to know about the failure of weight loss or weight regain once the patient would come to us, but here you have data where if the patient stands on the weighing machine, the data automatically comes to you. This is their endoscopic removal rate in this study, 1.2%. To be honest, my rate of removal is further less than that. We have done around close to 850 of swallowable balloons. Only at our center, we removed 3 of them. So it's like pretty much, not that big as number of 40 to 50% for the previous generation balloons which were put in by endoscopy. Again, let's talk about the lifestyle management. Most patients ask us this question, that why we cannot do the same amount of 14% total weight loss with lifestyle modification, but we know that lifestyle modification alone or lifestyle modification with ellipse balloon, the rate of weight loss is much better. So you can see by this graph that 7.9% versus 13.2%. It's significant. So obviously, lifestyle modification alone not going to work. This is much better as compared to the lifestyle modification. You can modify your lifestyle with a swallowable capsule. So I would say that the virtual follow-up clinic or the telehealth approach Allurion has taken is the way bariatric surgeons should move forward with their bariatric surgery practice. So I purchased virtual care suites for all my bariatric surgery patients, and these days we are giving weighing machine and health trackers to even our surgical patients, and the confidence in my program has increased fourfold because that no other surgeon in India is doing at this point of time. So, the virtual follow-up is going to be the way, and that is what we have to learn. Let's talk about last 3 slides, the diabetes and pre-diabetes. So Allurion balloon has some emerging data about the type 2 diabetes and pre-diabetes treatment. We will come up with our own data, but this is from 5 different obesity centers. They took 226 patients, and what they could actually get out of this data is that out of the glycosylated hemoglobin fell in 1.5 in the diabetic range and 1.1 in the pre-diabetic range by the Allurion swallowable capsule. And that's a good resolution of diabetes. We have to see that whether that significant reduction in HbA1c in just 4 months are seen in the Asian set of patients. And I'm going to present that data very soon. We are coming up, and let me tell you, it's much better than what they demonstrated here. In adolescents, yes, this balloon can be used in younger patients. In India, it is approved to be used to anybody above the age of 15 years. So we are pretty much getting there. We have to bring more data to use it in even younger set of patients, but this study concludes that this balloon is very effective for the treatment of obesity in patients who are aged less than 18 years, and it can be considered as a very useful therapeutic option. So it's approved in 62 different countries. Some of the major approvals are Canada, UK, and recently Brazil, which I think it's a big breakthrough because Brazil laws are not easy. I would congratulate Manuel and Benoit and Shantanu of their team to have got the Brazilian approval. This is our data. So if you see 725 patients, this paper is now almost accepted in one of the journals, so I'm not going to present too much on it, but the important thing is that the amount of weight loss is 13.6 and 14.3. 13.6 is in kilos and 14.3 at 4 months as a percentage total weight loss out of this swallowable capsule, which is what we said. 2 patients got their balloon removed 2 days after the balloon placement with the help of endoscopy. 1 patient died 10 days after the balloon placement, not related to the balloon, but had myocardial infarction. That must be pre-existing disease. 1 patient came out with vomitus. So this came out in the vomit of the patient. So we asked Allurion, they said, yes, it can come out in vomit apart from going out in feces, but it's very, very rare. But this we reported. So thank you very much. This is our team. Dr. Phoebe always taught me that there are different modalities to treat obesity, not one. And whatever you do should be determined by the profile of the patient and guided by the findings from the analysis of your own data, which is prospectively maintained. At this point of time, I would say that the device appeals to me because that's what I wanted for the 98% of the patients I was not able to operate. My finding from my own data is very honest. My bariatric surgery practice has increased by 10 to 15%. The bariatric surgery practice after using this, and I think Professor Cummings is going to throw a light, the more suboptimal procedures which is going to come into the market to treat obesity, the more the surgery is going to rise. Thank you so much.
Thank you, Mohit. I think because of the time, maybe we save all the questions at the end. So may I introduce our next speaker? Our next speaker is Dr. Liu Cha Amy. She is from Taiwan, and she is the bariatric endoscopist and obesity doctor in the BMI Obesity Center. We're working with CK Wang. And so today, she will give us a talk on endoscopic therapy as compared to bariatric surgery in low BMI patients. Thank you, Amy.
Good morning, ladies and gentlemen. I'm Dr. Liu from Taiwan. Yeah, I really let me thank Simon first. So to give me this chance to talk about the analysis on endoscopy therapy compared with the back surgery in low BMI 30 to 35. In fact, when I get this topic, I feel a little bit awkward to talk about this topic because, as you know, I was well-trained obesity medicine doctor and endoscopist in Taiwan, Cleveland, Harvard, and Johns Hopkins. But I also work with the bariatric surgeons and learn from the two most famous back surgeons in Taiwan. And I work with them already 7 years, as old as our IFSO APC. So after this talk, please do not ask me which one is better, because I think after my talk, everyone will have a ruler in your heart. You will know which way is the best way to give your patient the best treatment. So in fact, as we all know that the obesity is one of the leading risk factors for early death, and 8% of global deaths are result of obesity. But for the class 1 obesity, it's a little bit quite different. We found that mortality in this class 1 obesity group is just the same as the normal weight populations. But however, when they have more weight gains, they will have more higher prevalence of obesity relative comorbidities and also the death. So this is a vicious cycle. So obesity medicine is just like the preventive medicine. We need to know, we need to treat this kind of the low BMI, the class 1 obesity as early as we can. So it's really important to talk about in this kind of group, what's the best treatment for this kind of class 1 obesity. As we know that we have many different treatment ways. The first thing that we use is the traditional therapy. According to the meta-analysis, about 5 to 7% of the patient who under the intensive lifestyle modification, half of them can have the 5 to 7% of weight loss. And only very few of them can keep the weight for a long time. So, but anyway, only a little bit improvement of their weight, they will have some health benefits, like to decrease the diabetes problems. But it still cannot prevent the cardiovascular events, even we have some little bit improvement of their total body weights. So we go to our next step, that is a pharmacologic treatment. And under the CONQUER and SICKLE trial, that is the Contrave and Qsimia medications combined with the intensive life therapy, we found that about the 25 to 50% of patients can get at least 10% of total body weight loss. It's a better result than compared with the only lifestyle modification treatments. But however, we still need more long-term results to see if this regimen can still remain for a long time. So for the patients maybe who have more comorbidities, other treatments we can use is like the endoscopy or the bariatric surgery. You can find there's really lots of literature show that the bariatric surgery now is still the best way to have more weight loss results and comorbidity resolutions. Like the IDF or the SMBS or even the IFSO itself already have an official statements to state that the bariatric surgery, when we do this for the class 1 obesity, is really a safe and effective treatment. So today my comparison will between these two groups. So I will try to analyze on the indications first, because both of these treatments just is invasive treatments. And then I will go to the weight loss and comorbidities resolution analysis and also a brief summary. So these two are just what I said, is the invasive treatments. So it all needs the anesthesia. So in our center, we have the same consideration as the bariatric surgery, because we consider for the patient, BMI is not a very good indicators. BMI alone is a poor index of our adiposity. Just like what John told us yesterday, the obesity stigma, we need to consider lots of different things. If you want your patient to have the best treatment, you always need the patient-centered. Patient-centered treatment is the best way. So we need to consider the cardiometabolic risk factors, the phenotyping obese patients, anything. So sometimes in our center, for myself, I will use the Edmonton obesity scoring system to evaluate the patient if they are suitable for the surgery or not. So these are the pre-surgery evaluation that we will do, and also the Edmonton and EOSS. So if the patient belongs to the stage 4 or stage 3, for me, I will postpone the BET or the BS, and we can use more conservative treatments for them, because patient safety is always our first choice. If the patient is okay for the surgery, yes, we can see that there's really ample and robust data to show that the back surgery really have a very good weight loss and a comorbidity resolution in low BMI 30 to 35. So you can see lots of literature to show that. So I have a conclusion that from some meta-analysis, when we follow up for 1 to 2 years, you can see that the bariatric surgery group compared with the intensive medical treatment group, 87% of the patient have they can have 87% of excess weight loss compared with the 21% of excess weight loss with an intensive medical treatment group. And if we have more detailed analysis, the OAGB is still the best weight loss result compared with the sleeve. Of course, there are still many different surgeries, like from the literatures, you can see not only the sleeve, the OAGB, the RIGB, the SATIS, even the BBD you can use to treat these kind of BMI 30 to 35 categories. And you will see that is the meta-analysis include all of these surgeries together to show that all of these will have a very good BMI weight loss results for the bariatric surgery patients. And also very good improvement in the lipid profile, and almost 80% of them can have a total remission of diabetes. So the bariatric surgery now is no doubt still the best way to treat the low BMI 30 to 35. And when compared with intensive treatment therapy, you can see that for this is the class 1 obesity, they are still favor for the bariatric surgery. And different surgery have different weight loss results, so you still need to have a very detailed examination before the surgery, then you can choose the best surgery method for your patients. And also there are still many information to show that the surgery has a weight independent mechanism to have a more the remission of the comorbidities, just like they can have some variable changes in gut hormones or change the bile acid signaling, and also have some intestinal nutrition signaling that can improve the insulin resistance, and also some improvement of the glucose transporters in our intestine. So anyway, the bariatric surgery already have many studies to show that it's really have weight independent mechanism. But this now, for this part, still a weak point for our bariatric endoscopy. We don't have so many ample and so many studies to show that if we can still have the weight independence results of after we do the endoscopy therapy for them. But although they have a very good weight loss results, the side effects still we need to consider. So like the iron deficiency, the vitamin deficiency, reoperation, the leakage, everything. So for the bariatric surgery adverse events still high, so like the 6 to 8%. For the class 1 obesity, it's just the same as class 2 or 3. So how about our endoscopy therapy group? Because we really can find a very scanty meta-analysis or systemic review data on this part. So I will show you with the literature I can find and also the data from our center. So the first one is about the intragastric Botox injection. This is still not approved, the FDA approved in the United States, but we can do that in Taiwan. We already more than 1,000 cases already. So we follow them for almost 1.5 years. We found that the most effective body weight loss is at about the 6 months after the treatment. the excess weight loss can reach to 50%, but when the drug's effects goes away, the patient will have a weight regain because they have a desire back, their eating amounts back. So after follow-up for 1.5 years, about the 36% of excess weight loss can achieve. But for the diabetes remission, we found that it's still weight dependent. We can't find any other weight independent mechanism through the intragastric Botox injections. And then second one is about the balloon. Balloon, because here we do is the Obera and the beep. We don't have Allurian right now, but according to Mohit's presentation, it seems a very good result. I'm really looking forward to that in Taiwan. So anyway, from the data that we have, now we use, at the time we removal of the balloon, it's about 64% of excess weight loss. But however, the weight regain problem is still very high during our Taiwan population. So after 2 years, it's only 18% excess weight loss. And according to some meta-analysis, when the 6-month day removal of the balloon, they can achieve about 55% of excess body weight loss. But after 3 years, it's only 29% of excess weight loss. So weight regain problem still that we need to resolve after we use the balloon treatments for the BIB and for the Obera. But however, you can see that for the diabetes remission, liver function improvement, or lipid profile improvement are still very good when we use the balloon treatments. And then is the ESG. ESG we since last year in Taiwan. We have 20 patients right now and already follow up for almost 1 year. We found that the 75% after 1 year, they can, after 1 year, 75% excess weight loss we can achieve. And according to the Abadaya and the NATO, they have the merit trial this August. That we found that after 2 years follow-up, they can have an excess weight loss of about 50%. And they have also a very good remission of the diabetes, liver function, lipid profile. And according to the merit trial, 80% of the patient, at least one of the metabolic disorders can have a very good, some degree of the improvements. And all of these have a very low adverse events, less than 2%, and no mortality. And this is a study done by the Dr. Nato. We found he focused on the ESG and on the class 1 obesity. You can find that after 1 year, it can achieve to 60% of excess body weight loss. So this is data from our center. You can see that in the Botox, they can achieve the maximum weight loss at the 6 months and slightly of the weight regain after the 6 months. The balloon and also the ESG. Now the ESG is still in Taiwan the best treatment for our endoscopies and have the best weight loss result and can last for longer. And some meta-analysis also show that if we do the balloon compared with the class 1 or class 2 or 3 obesity, you can find that for this class 1, it still have a better weight loss results and comorbidity resolutions when we do the endoscopies. Also the same for the ESG. So maybe for the class 1 obesity, our endoscopy is also one of the, maybe some of the choice that we can use to treat this kind of obesity group. And the adverse events from the meta-analysis, just like what I said, is very, very low. So this is a very brief and summary table to show that the back surgery, endoscopy, and intensive medical treatments, we can see that for the weight loss, the bariatric surgery still can achieve 60 to 83% of excess body weight loss. For our endoscopy, according to different kind of treatments, 36 to 75 excess body weight loss we can achieve, but for the an IMT group, only 21%. So no matter what kind of treatment you choose, both of these are much better than the medical treatment alone. And for the comorbidities resolution, for the surgery group, endoscopy group, all the studies and literature showed now, they have a significant improvement of all the metabolic disorders, but not for the intensive medical treatment therapy group. And the adverse events is for the medical group and the back endoscopy group still much lower than compared with the surgery group, and that's also the same for the quality of life. So for the indications, for us, the endoscopy and the surgery are the same indications to do these invasive treatments. If your patient has some comorbidities like the diabetes, and you can also consider to follow the DSS2 consensus, then you will have a clue how to choose your treatment for your patients. And for the weight loss and comorbidity results, for the weight loss, of course, still the bariatric surgeries are still a little bit more better than our endoscopy therapy. But how about for the long-term results? Because all of them will have the problems of the weight regain. So how can we maintain all of this weight loss and comorbidity resolution for a long time? That's the lesson we still need to work on in the future. But anyway, both of them better than the intensive medical treatment. So who is the winner? For me, in fact, there's no one is winner because both of them are good. But only consider and choose the suitable treatment for your patient is the best remedy. That is my presentation. Thank you very much.
Thank you very much. I think we'll have our last speakers. Is our last speaker here? Oh, yes. I think Amit Medeo apparently is a very famous endoscopist in India. I think he's definitely fit the topic of the theme today that we designed about teaching us about bariatric endoscopy. He has done a lot of research and also basically recognized for a lot of prize in India regarding of endoscopic surgery. So I think you can tell us what's going on there. Thank you.
So I'm using another laptop. So before I begin, I just want to thank the organizers of this conference and of course IFSO, AAPC, and my good friend Mufi from Mumbai for inviting me for this program and to talk to you on bariatric endoscopy options. And I would also like to thank Professor Manuel Galvao, because of whom actually I got into this field, myself as well as Mohit. We learned from Manuel Galvao the technique and the art of doing endoscopic sleeve gastroplasty, after which both of us almost same time started this program in India a few years back. So we heard 3 excellent lectures before this. So I'm going to talk to you now on an update on bariatric endoscopic options 2022. Just to give you an idea, obesity is on the rise, not only everywhere in the world, but also in our country, in India. You see here from this recently conducted cross-sectional study all over the country, the overall prevalence of obesity in India is quite high, almost 40.3%. But what is more interesting is most of the obesity in our country, in India, is central obesity or visceral obesity. And therefore, majority of these patients are tending to develop comorbidities even at low BMI. In fact, it is because of this that the classification of BMI and the chances of developing comorbidities is now slowly changing, and this is a new proposed classification in Asians where even at low BMI, they are shown to have an increased moderate or severe risk of comorbidities. If you were to see the various treatment modalities for obesity, we just heard a lot of them, right from lifestyle modification to surgery. Of course, the results of surgery are the most robust, they are the strongest. These surgical procedures are very aggressive. But at the same time, they can be associated with increased risk. So obviously, more aggressive the procedure, more risk is involved in these techniques. Surgical techniques have resulted into extremely good data, good results for treatment of obesity and metabolic syndrome. You see here various types of surgical procedures. In fact, it was and it presently remains the gold standard of treating patients of morbid obesity and various types of obesity. The only problem is, in spite of the best of surgical technique, there can be some adverse events. The chances of major adverse events is of course now lessening because of the advances and the refinement of the technique. In spite of all this, because of these adverse events, only less than 1% of patients get convinced to undergo bariatric surgery. And a very interesting data you can see here, that if you were to see how much amount of weight loss is actually required to reduce the chances of comorbidities associated with obesity, and from this data you can see here, which was published in 2021, all that you require is a reduction of around 10 to 12% of the total body weight to have almost a 90 to 95% reduction in the comorbidities. Now, can we achieve this 10 to 12% total body weight loss by simpler techniques which are not so aggressive? Yes, that is a possibility, and that is exactly the reason why over the last few years, bariatric endoscopy with associated with adjunctive pharmacotherapy is now evolving as the treatment for this middle of the road approach. These patients who don't want to undergo surgery, who have got class 1, class 2 obesity, and even at a low BMI, they tend to develop comorbidities. Well, out of the bariatric endoscopy options, the first and foremost is of course gastric space occupying therapy like the gastric balloons. We already saw Mohit talking about the Allurion or the ellipse balloon. The three balloons which are commonly used in clinical practice all over the world is of course the Orbera, then we have the adjustable balloon which is the SPATS, and the third is the swallowable balloon which is the ellipse or the Allurion balloon. This is very recently introduced in India now, the Allurion. And if you see, this technique of placing a balloon is quite easy, and the most accepted indication is for primary treatment of class 1, class 2 obesity. It can be used as a preemptive therapy for various problems like sleep apnea, hypertension, bridge therapy before bariatric surgery or liver transplant, treatment of NASH. There are some contraindications for placing the balloon, because we have found that if the patient has portal hypertension, severe gastritis, these patients don't tolerate the balloons so well. And if there is portal hypertension, hemorrhagic gastritis, the patient can come to us with problems after balloon placement. And in addition to that, of course, pregnancy and a large hiatus hernia. So what is the data on various balloons? You can see here three commonly utilized balloons: Orbera, the SPATS, and the Allurion. Average approximately total body weight loss at around 12 months, again, is around 10 to 12% for all the three types of balloons. So this is a good therapy. It's a relatively simple treatment to do, placing the balloon. Majority of the times it can be done on an outpatient basis. Only in some patients we may have to admit them if they have a lot of retching or problems after balloon placement. The second and the most commonly practiced treatment of bariatric endoscopy is restrictive procedures like endoscopic sleeve gastroplasty. And you see here, in this, the technique is of course to place an endoscope inside, and after going in, what we do is we basically suture or plicate the greater curvature of the stomach, starting from the just proximal to the incisura angularis, and we keep on plicating the greater curvature and stop just before the fundus of the stomach. And hopefully this is a full thickness suture. For this we use a suturing device which is called as the Apollo suturing device. There are various types of suturing patterns, but the most commonly followed suturing pattern is a U-shaped pattern. Starting distally, slowly coming upwards, 4 or 5 plications are done until the entire greater curvature of the stomach is plicated, and we reduce the size as well as the length of the stomach by almost 40 to 50%, as you can see here. And again, the most commonly accepted indication is class 1, class 2 obesity, treatment of comorbidities, and a new evolving indication is, of course, weight regain after lap sleeve gastrectomy, where the stomach has again enlarged in size. There are again absolute contraindications like portal hypertension, coagulopathy, etc., and a few relative contraindications. The commonly used device is this device, which is placed on a double channel endoscope. You can see here, in some countries, there is a device where you can also utilize on a single channel endoscope, which is still not available in our country. Now, this is the various equipment which we use for the endoscopic sleeve gastroplasty. So this device is fitted on the channels of this double channel endoscope, and then this needle is transferred from one bridge to the other. So this is how the actual procedure is done. The device is attached to the tip of the scope. We have passed the endoscope along with the device in the stomach. You can see this is the incisura angularis, and just proximal to the incisura angularis, we start the suturing, starting on the anterior wall, go all along the greater curvature, go towards the posterior wall in a continuous fashion, And then once we have reached the posterior wall, we again take a U-turn and then go upwards to the anterior wall, and then we tighten that suture, by which what happens is not only the size of the stomach along the mid-body reduces, but because there is a distance between the two in this loop, even the length of the stomach reduces. Well, by doing this, what we can do is we can completely plicate it. It's very important here that we leave the fundus intact. This is intentionally done because that allows the food to remain in the fundus, it distends the fundus, and thereby the patient has early satiety, and also it reduces the gastric emptying because of the suturing itself. Well, after doing the endoscopic sleeve gastroplasty, after performing the suture, you can see here, if you compare it before and after the procedure, you can see that it almost looks like a tube, as if you have done a lap sleeve gastrectomy. So it's almost akin to that. Of course, the durability of this procedure is a little different from that of a lap sleeve gastrectomy. But what is the main advantage of an endoscopic sleeve gastroplasty is that it maintains the anatomic structure, maintains the innervation, maintains the blood supply, potentially reversible, reproducible, repeatable if required. It is safe. No major serious adverse events. It's more durable than the balloon. And of course, it also can be upgraded by surgery. What is the data on endoscopic sleeve gastroplasty? This was the earliest large cohort study published from Saudi Arabia. You see here 1,000 patients, and at the end of 18 months, there was a total body weight loss of approximately 15%. This was a very realistic data where they showed a few adverse events, but these were not major adverse events. None of these patients required any major intervention because of the adverse events, but reasonably good data. The next, of course, was in 2020, a systematic review and meta-analysis published on endoscopic sleeve gastroplasty. Once again, total body weight loss between 12 to 24 months was 17.2% from this meta-analysis of 8 studies from 2016 to 2019. The same group from Saudi Arabia in 2022 published this data, which was actually a non-inferiority propensity score matched comparative study between endoscopic sleeve gastroplasty and lap sleeve gastrectomy. And you see here, as far as the total weight loss is concerned, there was not too much difference, 14% and 19%, as you can see here, whereas even in the comorbidity remission, it was almost similar results between the ESG and the lap sleeve gastrectomy results in this comparative data. Very recently in 2022, Barham Abu Daye from Mayo Clinic has published the effects of endoscopic sleeve gastroplasty. How is it so effective? And he studied the effects on gastric emptying, gastric motility, and the hormones. And he showed that the most important factor because of which ESG helps is it delays gastric emptying. So you see here that because of this suturing, what happens is the stomach does not empty fast. The patient feels early satiety, does not feel hungry for at least 5-6 hours, and this is exactly the main reason why it causes weight loss. In fact, he has shown that there was no major effect on the gastric hormones after doing this procedure, but most important was it delays the gastric emptying. And this finally very recent trial, the MERIT trial, which was mentioned before, just published in 2022. Now this was a prospective multi-center randomized trial from 9 centers from the United States. And you can see here the effect at 52 weeks where ESG along with lifestyle management was extremely good as compared to lifestyle management alone in achieving a total body weight loss nearing almost 15%. Another gastric restrictive procedure similar to endoscopic sleeve gastroplasty is called as the pose procedure. Now in the pose procedure, again the principle is same, to plicate the greater curvature of the stomach, but instead of using a suturing device, they use a plication device. This is a little different type of a device where anchor sutures are placed. The champion of this procedure is of course Gontran Lopez Nava from Spain, and vertical and horizontal sutures are placed by which again you plicate the stomach. This was a very recent prospective multi-center study on the POSE 2 procedure which has been shown on 44 patients. Similar type of data, mean total body weight loss at 12 months was 15.7%, and overall improvement in the lipid and liver profiles at 6 months. And at 2 years, they found that all the plications were quite intact. Finally, endoscopists now slowly have also started venturing into doing procedures which can alter the metabolic parameters in these patients by doing some metabolic procedures. And first and foremost, these procedures are of course more in the clinical trial stage. They are not still clinically applicable. The first is either bypassing the foregut or replacing the mucosa of the foregut. by using a duodenojejunal bypass sleeve or doing duodenal mucosal resurfacing. Now, this is the earliest procedure of doing this. Endoscopically, you can place such type of a sleeve, which is actually fixed at the pylorus because of these anchors. Now, this is a silicone tube, a fluoropolymer tube, which goes all across the duodenum, almost till the proximal jejunum. So what happens is it bypasses the abnormal enteroendocrine cells in the duodenum, and thereby it increases the insulin sensitivity because the nutrients get exposed earlier to the small bowel. Well, initial pivotal trial, which was started in United States in 2014, had to be stopped in 2015 itself because there were some adverse events related to by placing this duodenojejunal bypass liner. Because of the anchors at the pylorus, it led to abscess of the liver, and because of which the trial was stopped and the CE mark was taken away from this company. But this, you can see here that this open label randomized control trial continued in the UK from 2 academic centers. But the funny part is, at the end of 2 years, they realized that there was no significant benefit in anything, neither for total body weight loss and neither the improvement of HbA1c. So therefore, this device is now still undergoing modification, and it is presently not available for clinical use. The next is duodenal mucosal resurfacing, where this catheter is used, and in this balloon we fill hot water of almost 90 degrees, and the duodenal mucosa beyond the ampulla of Vater till the ligament of Treats, till the DJ flexure is ablated. So thereby what happens is it destroys the abnormal cells which are in this area and then allow new cells to grow, and which hopefully will improve the metabolic parameters of this patient. Well, what is the data on this? You can see here a systematic review and meta-analysis which is recently published on 4 studies, which include 1 open non-randomized single-center study, 2 international multi-center studies, and 1 RCT, 127 patients total. There are 3 ongoing clinical trials, but overall, if you go to see at 6 months, HbA1c, there was a drop by almost 1%. So 0.94% of drop in HbA1c. There was no change in the weight loss, or there was no change in the reduction of ALT and AST. So again, this is still undergoing clinical trial, still not available for clinical practice. And finally, which is likely to be probably one of the most robust endoscopic procedures, is going to be an endoscopically created bypass from jejunum to the ileum. Now, this can be done by an incisionless magnetic anastomosis system, where it has been shown that through a colonoscope, we can release hexagonal magnets in the jejunum as well as in the ileum. And once the magnets come in approximation with each other, then the area in between necroses off in a period of 2 weeks, and you create a partial jejuno-ileal diversion. Now, with this, you can see here the initial data, the single arm, the first in human pilot study published from this Czechoslovakia, along with Dr. Christopher Thompson from United States in 10 patients, type 2 diabetes, pre-diabetes, and no diabetes. Results, all anastomosis which were done by these magnets were patent at the end of 1 year. Total body weight loss and excess body weight loss, 14.86% total body weight loss and 40.2% excess body weight loss. But more important is, there was a drop in HbA1c by almost 2% at the end of 1 year. So this is likely to be an extremely robust and a good endoscopic technique. So in the future, there is a possibility that if endoscopists are asked to treat these patients who don't want to undergo surgery, then we can do a combination of different types of endoscopic procedures on these patients, like doing an endoscopic sleeve gastroplasty, along with a magnetic anastomosis if they also have altered metabolic parameters. And along with this, the patient can also be put on proper pharmacotherapy. So latest data, 2021, what is the role of bariatric endoscopy? Presently, there are only 2 or 3 modalities which are presently available in clinical practice, balloons and of course the suturing devices. And both these presently can achieve a total body weight loss anywhere in the range of 15 to 20%. The gastric restrictive procedures are a little bit better than the balloons. And in addition to that, probably if the magnetic anastomosis or the DMR, if it comes into clinical use in the future with robust clinical data, maybe they can also be added. So, as was rightly stated by Mohit, and other speakers that obesity is not a very simple disease to treat. You need a multimodality approach. It has to be patient specific. And you have to give the patient a modality which is least aggressive, but which can be maximally effective. But most importantly, the behavioral modification has to be done, because whatever treatment you do, the patient has to continue proper lifestyle management in the future to maintain a more robust result. Thank you so much.
Thank you, Amit. Thank you all the speaker. Because we are a bit overrun in this section, so I think we will leave the question for the outside tea break, so you can ask them. And before we go, may I present the certificate to all our speaker, Mohik and Amy and Amit. And can we take a picture for us? Yeah. Yeah. So everybody come to stage.
So we should start the next session so we can keep the question in the long term. Introduce the next session's chair. I think it's Sutep and also Mia Forrest and Shishi Liu. Okay, so
Good morning, everyone.
and
Good morning,
also, I
attendees.
think,
Could you please type in yes in the
Raymond
chat
as
box if
well.
you can hear me,
Raymond says,
please?
are they all present?
Yeah. Go we can start.
Hello? Hello?
Thank you very much, Lemon. Can you come here? And Mia? Yes, welcome. No, you have to sit here. What do you want more, chair? Come. Okay. So I think it's time to start the second session of this morning, which is going to be very interesting. It's about the medical therapy approaches in obesity management. What's new? And I'm guarantee to you that we are excited to listen to our, actually you've been listening him already for the keynote yesterday for the evidence of the diabetes remission from yesterday. And today he's going to be talking about weight loss taps and jabs. Can they replace a surgery? So very, very exciting topics, and it will be delivered by Professor David Cummings from USA. Thank you very much, David.
So the organizers are working to get my talk pulled up. This is the previous session. We need the current session. There you go. That's it. Yeah, thank you. And you got to put it up there, guys. There you go. All right, it's working. Good morning, everyone. Welcome. Thanks for joining me. It's my pleasure today to talk to you about the use of prescription weight loss medications. I thank the organizers for inviting me, and I thank Kwang Wei Tam for this very clever title that she supplied, Weight Loss Tabs and Jabs. Can they replace surgery? The following is a list of the currently FDA-approved available weight loss medications in the world, all of which are available to me in my clinic. I think, though I've learned that some are not to you folks. An old one is phentermine, a noradrenergic agent. Another old one is orlistat. It's a GI lipase inhibitor that blocks the enzymes required for the absorption of dietary fats. Those fats end up in your colon. The anaerobic bacteria then say, yummy, that's lunch. They eat it, produce a lot of gas and a lot of other nasty things that pretty much make you feel terrible if you've eaten a fatty meal. So it's kind of like antabuse against pizza. Then the next two medicines are things where two medicines were combined, medicines were combined which were developed and used for other purposes and found incidentally to be causing weight loss. The first one is Contrave. It's naltrexone plus bupropion, a noradrenergic agent plus an opioid antagonist. I spin a story to my patients that this causes weight loss by stimulating metabolic rate and dampening down the rewarding feeling you get from eating highly palatable foods. I don't really know if that's why it works, but it does. Then you have Qsymia, the same concept, two other medicines that presumably work through different mechanisms that were designed for other purposes and combined have additive effects. In this case, it's a noradrenergic agent and an anti-seizure medicine. I'm pretty sure we have no clue why this actually causes weight loss, but it does. Then you have the first GLP-1 receptor agonist, Saxenda. This was developed for diabetes treatment, but at high dose, 3 milligrams a day. It's marketed for obesity alone in the absence of diabetes. Then semaglutide I will talk much more about in the future. And when I first started the weight loss clinic and program in our hospital system, we had access to lorcaserin. That's since been taken off the market. It's a 5-HT2C receptor agonist. It was implicated as a potential cause of cancer. So now I'm going to show you data from each of these medicines that shows how much weight loss they use in the various clinical trials, the pivotal trials that got them marketed. And in each case, there were randomized trials of the drug versus the placebo, blinded, and the placebo group always loses some weight. So the most important way of assessing the effect of the drug is to express the weight loss as placebo-subtracted total weight loss. So this is orlistat. Over about a year, you get 3 to 4% placebo-subtracted weight loss. It's statistically significant, clinically meaningful, but pretty damn piddly. This is phentermine. It's a complicated slide. Here's the phentermine data, a little better, 4 to 5% weight loss. Here's Contrave, naltrexone plus bupropion. We have a little bit better still, 5 to 6% placebo-subtracted weight loss. Qsymia, phentermine plus topiramate, better still. Here's about 7 to 11% weight loss. Saxenda, that's high-dose liraglutide, about 6 to 7% weight loss. This is total weight loss, by the way. We've heard some stuff about excess weight loss. I'm expressing it as total weight loss, which is the better metric for using. So here's a combination graph showing several of those. This is orlistat, Saxenda, Qsymia, and Contrave. And in each case, the solid line is the drug, and the black line is the drug, and the gray line is the placebo control for that particular trial. Overall, placebo-subtracted weight loss of about 3 to 8% from these various drugs. So that's the way the world was for a long time. When I started our weight loss program in my hospital, that's what I had to deal with and work with for many years. That's the way it was until June 4th, 2021, when the world changed. On that day, there was a report from ABC News and many others, I remember, saying the title was "Newly Approved Drug Heralded as Game Changer in the Growing National Obesity Crisis." This was a drug put out by Novo Nordisk. That article started with a statement, "A new weight loss medication is being heralded by some health experts as groundbreaking, a potential game changer in the growing obesity epidemic." And although this is news and you kind of take it with a grain of salt, I don't think this is hyperbole. So we're obviously talking about the new GLP-1 receptor agonist, semaglutide. It was previously FDA approved for treatment of diabetes, and now it was approved on June 4, 2021, for use in obesity alone in the absence of diabetes. Now, GLP-1 and the GLP-1 receptor agonists have many effects on many body weight systems, on many body systems. The ones probably most pertinent to body weight are the brain, where they decrease appetite, and the GI system, where they slow gastrointestinal motility and enhance the feeling of satiety and satiation, which are slightly different things. Semaglutide was approved for weight loss alone based on the results of 4 trials that were called STEP trials, published in early 2021 in the likes of New England Journal and JAMA, all of which showed very favorable results in various different populations. So the STEP program is very large. Step 1, 2, 3, and 4 were those trials. There's now also step 4, 5, 6, 7, 8, and 9 trials. Also, there are specialty ones for heart failure, and importantly, can I point here? Yeah, there we go. This one, the SELECT trial, is an ongoing cardiovascular outcomes trial, powered to see whether semaglutide used in people without diabetes can actually reduce cardiac events, as it's been shown in the LEADER trial and others, to reduce such things in people with diabetes. So SELECT will see whether that's true without diabetes. I'm just going to show you some results from the STEP 1 trial. That's kind of the prototype trial of semaglutide. It was a randomized trial of semaglutide versus placebo, that's it, in people without diabetes. So semaglutide is dosed in a gradual up titration from a really low dose, a little bit higher still, over several months to reach the final dose. So it's a stepwise up titration, which is why the trials are called STEP. In addition, it's a clever name, that stands for semaglutide treatment effect in people. So here's the familiar weight loss curve, like I've shown you with the other drugs, for semaglutide in the STEP 1 trial versus its placebo. But now we've got 14 to 15% weight loss. So this is 2 or 3 times greater weight loss than we've seen in any other weight loss medication in the past, and it truly is a game changer in the field. That's the average weight loss for the study protocol. I like to look at this also as the categorical weight loss. The categorical means the percentage of the study subjects who achieved a particular threshold weight loss. So in step 1, the percentage that got to 15% weight loss was 55. Those who made it to 20% were about 35% of the group. Now, what about the safety? So pretty much all the side effects are in the GI domain. The first 3 of them, nausea, vomiting, and constipation, are basically overextensions of the mechanism of action of GLP-1 itself, which slows GI motility, and the extreme of that, if it goes too far, can be these symptoms. For reasons I don't understand mechanistically, some people get diarrhea in addition, and that's pretty much all you get. Now, I've learned from Mohit, as well as Shashank Shah at this meeting, that this is a real problem among Asian patients, apparently like universal. And he's nodding his head. I haven't had that kind of problem in my practice, and it's not described as much in the United States as a big issue. Yes, these are the main side effects, but they just don't occur very often. So I do not know if that's really a real finding, why that would be different in the States versus India. Step 3 was the same concept as semaglutide versus placebo's trial, now with a major lifestyle intervention added on top. So with that added benefit, on the left panel you see the weight loss is now more like 15 to 17% instead of 14 to 15% without it. So it's a little bit helpful, but the majority of the effect here is the drug, and you can't get much added benefit in these trials by adding on a major intervention in lifestyle. This is the categorical weight loss from that step 3 trial with semaglutide and lifestyle. It improves a little bit better. Those who got to 15% were 56%, and the percent who got to 20% weight loss was 36%. That's slightly better than without the lifestyle intervention, but not very much. So finally, we've got a medicine that fits into the so-called therapeutic gap. This was shown in a prior speaker. So it's been known for a long time that you have interventions that are not invasive, or not very invasive, and not very effective, like lifestyle modification and the pre-existing weight loss medicines. And at the other end of the spectrum, you've got things that are very invasive and very effective. So that's metabolic bariatric surgery. And then in the middle, for a long time, there's this yawning gap of not much stuff. So for all those folks who are not willing to undergo surgery, they might be willing to do something a little bit less invasive, but they'd like it to work better than plugging away at the diet, exercise, and medications. And that's where these various endoscopic procedures have been trying to fill the void. So balloons, and gastroplasty, aspire, sit, and so on. And then, as you've just heard, they do fit that void. Finally, with semaglutide, you have a drug that's right here in the middle, causing about half as much weight loss as is achieved with most metabolic operations, with intervention that's not invasive. This has changed things dramatically. So I'm showing you data on the usage of semaglutide in the national VA system in the USA as of just recently, and the pie chart shows green is the use of semaglutide as a percentage of all prescription weight loss medicines in the nation in the VA system, which is the largest healthcare provider we have. In a little less than a year, semaglutide has gone from 0% usage for weight loss to about 25% of the market for that. That's the national VA system. I work in the Seattle-Tacoma VA system, and I'm very proud that we are doing even better. So we've moved from 0% use of semaglutide to about 70% of our prescriptions for weight loss medicines are semaglutide. We are actually the #1 VA system in the nation for semaglutide usage by a long margin, about 60% more prescriptions per year than the second most heavy user, which is Stanford. We're probably going to get into trouble someday for spending too much money, because this stuff costs about $1,000 a month, and you could get a gastric bypass after just using this for 2 years. But I'm proud of it because this is a very helpful drug, and we're helping a lot of vets. I'm now going to turn to a new kid on the block, tirzepatide. Now, this is not yet approved for use for obesity alone. It was developed as a diabetes drug and is approved for that purpose. Tirzepatide is a dual GLP-1 and GIP receptor agonist. So those are the two incretin hormones in the body. Hormones that are gut peptides that are released in response to a meal that help you stimulate insulin secretion to deal with the meal. The K cells in the body down in the proximal intestine make GIP. The L cells, primarily in the distal intestine, make GLP-1, and semaglutide stimulates both. So the combined effects of these are insulin secretion, as said, and then also to slow gastrointestinal motility and enhance both satiation and satiety. So tirzepatide was approved for use for diabetes in the fall of in the early 2022, based on 4 publications for diabetes usage in the fall of 2021. And those were published in Lancet and New England Journal and the like. And all of them showed really great results. I'm going to show you data now on one of the STEP trials that was expressly for people without diabetes. So this was an N of 2,500 plus, and nobody had diabetes. And the question was, can we use this as a weight loss drug per se? Up in the upper right corner, you see the familiar curve like I've shown you before. And what you see are 3 different doses of tirzepatide, which now in the higher doses cause about 21% weight loss. So about 15% for semaglutide, now we're up over 20%. That's the average weight loss. How about the categorical? The percentage of people in this trial who achieved 15% weight loss was a whopping 78. Those who got to 20% weight loss was achieved in 63% of cases, and now 25% weight loss was achieved in 40% of cases. So that's getting pretty close to surgery. It's not there yet, but it's knocking on the door, and it may compare well with, say, gastric banding. So based on these data, tirzepatide is now under FDA review for expedited approval. There's a new SURMOUNT trial being done, but I'm told that FDA approval for tirzepatide to be used in the absence of diabetes as a weight loss drug is expected in this coming winter or fall, the spring. I think when tirzepatide gets approved, it's very likely it will, semaglutide, as good as it is going to disappear. Because why would you use semaglutide when you've got tirzepatide that has all the power of semaglutide plus the GIP effect? And so we're going to look back on semaglutide and thank it for its historical role and then replace it with tirzepatide. So how about tirzepatide head-to-head against semaglutide? That was done in one of the SURMOUNT trials. This was a trial designed for diabetes treatment, but they did report as a secondary outcome some weight loss. So this was an N of 1,879, all with diabetes. And you can see there on the right side the average weight loss. In this study, semaglutide didn't do so well. The average weight loss was 7% instead of 15%. I think that's because for some weird reason they stopped at half the maximum doses of semaglutide. So they didn't push it all the way to the top. And then they used low, middle, and high doses of tirzepatide. Even the lowest dose of tirzepatide surpassed that of semaglutide, and the highest dose was about twice as much weight loss with tirzepatide over semaglutide. I'm going to close with a discussion of a new medicine that probably most of you haven't heard of, CagriSema. It's a combination of semaglutide, a GLP-1 receptor agonist, and cagrilintide, an amylin analog. Now, amylin analogs have been played with by drug companies for years trying to market them as an anti-diabetes treatment and or obesity treatment. They haven't really had much traction in the market, but now we're trying to see whether this amylin might help improve the effects of semaglutide. They'd be working through two totally different mechanisms. So the combination is a weekly injection, just like semaglutide is, and I forgot to mention that semaglutide's cool because you only have to inject it once a week instead of once a day for liraglutide. And the reason I'm mentioning this is because a press release just came out about something that's going to be announced in Obesity Week in San Diego, which means it's probably about to be announced right now because obesity is happening today and tomorrow. According to the press release, there are results that will be reported of a phase 2 randomized trial of CagriSema versus of each of its separate components. So it's a three-way RCT of CagriSema versus semaglutide versus cagrilintide. The patients were all folks with diabetes and obesity. They had an N of 92. The A1C lowering with CagriSema was 2.2 points, which was significantly better than it was with each of the individual components. And then in terms of weight loss in this 32-week study, about 16% with CagriSema, and that was substantially more than each of its separate individual components. For reasons unknown to me, and it's just a press release, the results with semaglutide were really wimpy, only 5% weight loss, and how do you pronounce that? Cagrilintide, cagrilintide, thank you, Mohit. If you put them together, you get about the results with semaglutide, with CagriSema. So, although this weight loss with semaglutide is wimpy, in a direct head-to-head comparison in this trial, clearly the addition of the amylin agonist helped semaglutide to work even better. So keep tuned to see what's going on with that. This has allowed the phase 3 to move forward. That'll be the REDEFINE RCT, which is going to be starting recruitment in the last quarter of this year and the first quarter of next year. Pharmacotherapy has some major limitations, perhaps the most important of which is that there are no long-term outcome data related to hard obesity-related complications like cardiovascular disease and mortality. We know from the DIRECT trial and other RCTs that GLP-1 receptor agonists have been shown to reduce cardiovascular events in people with diabetes, but that has not yet been shown in people without diabetes. It's the purpose of the SELECT trial. There are very few data on directly comparing one prescription weight loss medicine versus the other, and most of the trials are not very long. The typical one's about a year. The longest I'm aware of is 4 years. So that compares poorly to what we have in metabolic surgery, where you have like SOS data, non-randomized, but prospectively matched, that go out to 30 years. And as I mentioned in my talk yesterday, I'm a principal investigator on the ARMS consortium of RCTs. We are going to be reporting at the time of the ADA next year, hopefully with concomitant publication, a paper that will report data on the largest yet cohort of people randomly allocated to surgical versus non-surgical options for diabetes, with results out to 15 years. So this data is wimpy by comparison to what we have for surgery. Now back to the title of the talk that Kwang Wei supplied me with. Are these new, more effective weight loss medicines going to reduce metabolic surgery usage? Are they going to cut away at the pie? And as Mohit hinted, I think the opposite is true. And admittedly, this is my opinion based on just my experience in clinic. Keep in mind, about 1% of people who qualify for prescription weight loss medicines use them now, and less than that who qualify for surgery have surgery. So the vast majority of people out there have obesity and have just given up and aren't doing anything significant to lose weight, presumably because nothing's worked for them in the past. What I'm seeing with semaglutide is that people are coming back to me, and for the first time in their lives, they've really lost some weight, some substantial weight, and they're like, whoa, I thought this was a life sentence. I was going to be fat forever. This I can change. I can actually make a movement on it. That was great. I want more. And then they say, okay, 15%, cool, I want 30. And then they go to surgery. So I agree with what my hinted that with these more effective treatments, it's my hope that more people are going to come to the table in the first place and seek therapy of any kind. And we're finally going to get to treat more of the 98% of people that were suffering in silence prior to this. That's my hope, and that's what I'm experiencing in clinic. Thank you, everybody. That's it.
Thank you very much, Professor Cummings, for your very comprehensive talk as well as the perspective for treating the patient. Thank you very much. Any questions? Yes, please.
So I just wanted to, I don't know know whether you have experience with the oral semaglutide in your country. I don't think it's approved in US as far as I understand.
It's not approved for me, yeah. I think maybe that's why your
Yeah,
people are so
I
nauseated.
think, I don't know about other countries here, but in my country specifically, uh, injectable preparations are not accepted. Patients, when they counsel them, they get very scared. Um, Oral preparations have more compliance in our country.
Yeah.
Although the injectables are weekly and, it will assure better results. I think in India specifically, oral semaglutide is going to rock. The one problem which we face with oral semaglutide, and I don't know in which countries it's approved, is a very erratic absorption. If you do not take the drug with 6 to 7 hours of complete nil by mouth, with exactly 80 ml of water and not eating anything or not drinking, even meds till at least 1.5 hours after the drug, the absorption is so poor that even the 14 milligrams is not effective. That's the downside of it. But if you have taken it properly, the results are tremendous. I don't know, but for reasons unknown to me, a 14 milligram of oral semaglutide is like a weekly thing. Even if you take it for a day, it gives effects for the whole week. So I think I'm seeing India going the oral way. So oral semaglutide would still compete with tirzepatide or any other drug which is injectable in my country. I don't know.
Except you're telling me that lots of people have side effects, right?
Yeah. The side effects are, in India, Professor Cummings, we recruit the patients with semaglutide in our program. They come back with very severe nausea.
Yeah.
They can't tolerate it. So much so that we have to stop the drug, and even if we reduce the dose, it's very severe. I have not seen that with liraglutide.
Yeah, so ironically, India has the advanced, more modern medicine and not the less advanced medicine. They've got the oral and not the injectables. Probably, if there is a difference where South Asians are having trouble with side effects and Americans are not, it's because of oral versus injectable delivery. That's just my guess. And maybe the oral is more prone to those side effects. I welcome to hear anybody else's experience. I've never had access to the oral stuff.
Oral has no, because I have heard, so I have a couple of my friends, even Manuel takes Ozempic, injectable, and he says that he will have nausea only on the first day he takes it for his diabetes. So nausea is only on the first day, but then the week is good. But with oral semaglutide, it's like every other day.
Interesting. You know, the injection is really simple. It's once a week. It's this pen. You barely see the thing. You go click. It's a tiny little needle. Nobody I've had has troubles. Questions there?
I guess my question, with weight loss surgery, the more effective the procedure, the higher risk we see of nutritional deficiencies, frailty, metabolic bone disease.
Right.
Are we expecting to see the same thing, I guess, with these medications? Because even if the number to harm is much higher, we're going to have a lot of people on these medications. Are the medications less worrying from that point of view, or are we still going to have the same, I guess, care around those problems of frailty, metabolic bone disease, malnutrition with the medications as we do with the surgery?
Shouldn't have. Off the top of my head, no, I don't think that's going to be true. Yes, it's true that with surgery, the more effective, the more complications. That's always been true on the spectrum from, banding to sleeve gastrectomy to gastric bypass to deep JV and so on. I don't think the same will be true with these medicines. For example, the side effect profile of GLP-1 receptor agonists is better than Contrave and Qsymia. And you would have no reason to expect nutritional issues. It shouldn't not be the case. Isuki.
Jackie from Japan. To maintain a good weight loss, people need to use this semaglutide forever. I would like to ask your view about this kind of drug is justified in terms of the medical or it's economical.
Yeah, great question. So I mentioned that in my country, semaglutide costs about $1,000 a month. So in 2 years, you could have paid for a gastric bypass. The Step 1 trial had a follow-up trial published not very long ago, which said, okay, how did those people in this trial fare after the study was over? And as soon as the study was over, they went off the medicine back to life. And a year later, they were pretty much back to where they'd started. And not entirely, but almost all the benefits of the treatment of the year on treatment with the drug were gone. Not surprising. So the mechanism of action would predict what is seen empirically. They don't work unless you're taking them. So it's not like surgery where you have it once and then it works for a long time. You have to keep taking it. So the financial issue is a major question. I mean, is a person going to be taking that much? Or what's the story on our financial burden if somebody takes this for 40 years? I don't think we know the answer to that, but it is a major reason to be concerned about sort of semaglutide versus surgery. And I suspect tirzepatide will be equally expensive. If these things are going to really hold for time, the price point's going to come down, have to come down. Thanks for your good questions.
Okay, thank you. So let's welcome our second speaker, Professor John Dixon. He's a professional research fellow in the clinical obesity research at the Baker Heart and Diabetes Institute in Melbourne. And also he's also the adjunct professor at both the School of Primary Health Care, Monash University, and the Iverson Health Innovation Research Institute. John is very famous clinical on the obesity research. So let's welcome John Dixon.
Thanks very much for the kind introduction. I'm going to be talking about behavioural change and using the treatments that work. I'll go back to that other one if you like. Bariatric surgery, very low-calorie diets and pharmacotherapy, and why we need to use all of the options that are at our fingertips to manage this disease. And it's not one size fits all. And remember, it's the patient that should be making the decisions as to what they want, and they will change with time. So, disclosures, particularly drugs and Nestle Health Science, they make one of the very low-calorie diets, which I'm going to talk about. Okay, so we have a health system, we have this support, we have the right thing for the right patient at the right time, and as you've already learnt, that doesn't happen with obesity. Less than 1% of people really get any effective treatment, and up to 5% will get any treatment at any time. We've had the past, we've got combination treatments now, we've got, and the future. We may look at drugs across the board, and we do remember the proton pump inhibitors and what it did to ulcer disease, so we may be looking down that path, but I think we've got time left. So when we look at behavioural change, and I heard already today that if we don't change the eating and activity actions of our patients, we will fail. Now, that's not true. You've seen the placebo results of all the drugs. It's between 1% and 4% of weight loss until they put an intensive program in. And when you put that intensive program in, and David's just shown the slide of the intensive phase, we see a very impressive early weight loss in the placebo group, but in fact it wanes over time. And most of the effects of the drug, just like most of the effect of your work, is the surgery. So when we look at what are the behaviours that we need to engage our patients with, we should be thinking from a framework of chronic disease management. The idea that we're going to be delivering treatment over a lifetime, and that we need a team effort to put that together. And I've put the team up there. And those people may all have different behaviours that they're looking to try and achieve. There might be eating lifestyle, eating measures. There may be psychological, the psychological supports, etc. We're looking to improve the outcomes and improve the quality of life. So when we look at the perceived activity of things that actually work, this first slide is from the Action IO. It's been done, we heard it yesterday from the Southeast Asia. We know the United States data is exactly the same as the world data, and I can tell you the Australian data is exactly the same as the world data. When we look at specific, we look at treatments, diet and exercise. Diet is the number one. We are going to treat this, there we are, 80% of healthcare practitioners. Remember, this was a study of healthcare practitioners and people living with obesity. 80% believe diet's the answer. When it comes to exercise, again, of healthcare practitioners, 73%. What world are they living in? They're people like us, they're healthcare practitioners. When it comes to specialised diets, some of which have a very strong evidence base. The patients, 48%, health practitioners, 29%. This is worrying. And when it comes to drugs, we can see here, 40% of patients living, 40% of those, can we act up? Yeah. 40% of those living with obesity, and this is prescription medications, and 30% of healthcare practitioners. They're not using things that work. And when it comes to bariatric metabolic surgery over there, 63% of patients living with obesity, and 38% of those of healthcare practitioners. These are alarming results, and they're telling us something very important about the beliefs out there in the community as to why this is a problem and why our patients believe that it's all their fault. So when we look at this Tom Wadden study that's done many years ago, the drug they used was sibutramine, but the medication alone, the medication and behavioural modification, which Tom does very, very well, and then with a meal replacement on top of that. Really impressive results at 12 months. Really impressive results at 12 months. So we have to think about how we combine treatments to suit this patient at this time. Now I'm going to talk about very low energy diets, very low calorie diets. And these are less than 800 kilocalories a day. They have a very strong evidence base. They are designed to replace entirely the calorie intake, the nutrients, etc., all the micronutrients, all the vitamins and so forth. So you can live on this, and you can live on this longer term. We don't use them as a sole entity, but we use them very, very carefully. They reduce hunger, and they reduce hunger by producing a very low level of ketones in the blood after a few days. And in fact, there's lovely data showing why the ketones and the association of ketones in the blood with the changes in gut hormones, the changes in some of the pancreatic hormones, and the levels of glucose after a meal and the levels of non-esterified fatty acids. So it's actually producing a very satiated state over a long term. And patients know this after just 3 days on this diet. So the key, of course, is the low carbohydrate. Now, what's the evidence base behind these? Well, a meta-analysis done in 2001, all the studies were last century, shows that this is the best type of diet that one can use for not only short-term weight loss, but long-term weight loss. In addition to that, so that was Anderson in 2001. There's a lot of data since. They can be used over long periods of time when needed. They're safe from a kidney body composition point of view. There's lots of data. Randomized trials, better weight loss. Rapid weight loss, by the way, produces exactly the same rate of weight regain as non-rapid weight loss. So there's, all the myths about these are problematic. High safety profile, excellent diet compliance. Only 80% of people can use these properly. Only 80% in our studies, multiple studies. So they just need the support. VLCDs, there are very few nutritional problems, in fact, none. And even in a study that was done in Melbourne on older people, their nutritional status was better at the end of the study. So indications, very much the same as pharmacotherapy, BMI over 30, BMI above 27, with medical-related complications. I never use the word comorbidities. Only complications. Diabetes has complications, obesity has complications. Not friendly bedfellows that, you know. Anyway, rapid weight loss, we often use them when it's desired. There's contraindications, pregnancy, older age, that's relative. We've got some data, and we would be careful with older people because of the potential loss of muscle. Recent myocardial infarct, which is exactly the same for any weight loss procedure. Organ failure, severe psychological disturbance that's not treated, illicit drug and alcohol abuse, and cautions, of course, with type 1 diabetes. But there are ways and means of using these treatments. Of course, what we tend to do is to put people on an intensive phase, go to a lower intensive phase, maybe replacing 3 meals a day initially with some vegetables and some olive oil or vegetable oil to contract the gallbladder and reduce the risk of gallstones, and some fluid. And then we can tailor it down. The interesting thing, though, with tailoring that is that once people have learned to use them, they can step it up again. And that's why people who learn to use these diets will actually use them for many, many years. I've got patients who've been using them for more than 20 years as their only treatment successfully to maintain 10% or more weight loss. So there's this ability to rotate them around. Now, of course, this was all very quiet until the DIRECT study came out, and that's where every endocrinologist in the world worked out that when you use these meal replacements, you achieve weight loss that's of the level of we're seeing now with some of the drugs and bariatric surgery. So look at this. This is the DIRECT study. This was done in primary care in the UK, and every endocrinologist in the world knows about it. And you see at the 2-year results, the achievement of 15% weight loss in 24%, not as good as semaglutide, and you'll see it at 2 years lower. But these are extraordinary weight losses sustained over years with this treatment. And and by the way, this was the diet here was 810, I think, calories, because they don't like using very low calorie diets. That's defined as less than 800 in the UK. So then you'll see the remission rates of diabetes there, and the remission rates of diabetes in relation to weight loss at the bottom. 86% at 1 year and 70% at 2 years for those who achieve 15% weight loss. Weight loss is our best treatment for diabetes. There's absolutely no doubt about that. We do have some symptoms that people get in the first week. We need to know about that. There's no way someone's going to pick this up off the shelf and use it and think it's and take it home. They're going to have some days where they've got dry mouth. They can have a little bit of physical. They need physical support in those first days. Orthostatic hypertension. Typical as you convert over to ketosis and you get that improvement in satiety, and you find that you can't believe you're on less than 800 calories and doing well. There are some longer-term issues with it, mainly related to weight loss. They're all sort of symptoms of weight loss. By the way, after it's a week to 10 days, all the energy comes back, and we've even put exercise physiologists who actually like to do marathons and very long distance stuff, and they've been perfectly well on a ketogenic diet. So it's interesting. It's a way of going. Now, when we look, so are we providing this for our patients? Because some of them will only need this. And of course, the best thing to do when someone's on one of these and putting on some weight, just add a drug. And it doesn't have to be one of the most expensive things, or the drug that we can't get hold of in most of the world because it's being used on veterans in the United States. So when we look at what's approved in Australia, we have exactly the same as what's elsewhere, apart from the topiramate and the topiramate and phentermine combination. And we use topiramate by itself, and we use topiramate and phentermine, but in the generic form we don't use Qsymia, and we don't want to use Qsymia, and I'll show you why. But we've got phentermine, we've got Xenical, and David's really explained all of these, and I don't need to go, only to say that we now have semaglutide, 2.4 milligrams, Wegovy, approved in Australia. Of course, no one's ever seen it, no one's got it, and most people around the world haven't seen it or got it, and so there's a massive problem, and so we can only dream of what's coming. But ICE's put out some data. This is from the United States. This is telling us, in summary, that there's greater weight loss with semaglutide and phentermine topiramate than other drugs. It's actually come second, and if you look, David, it's more. Many people will actually achieve 10% weight loss on that drug, and a lot of the benefits are there in 10%. We don't know a lot about the benefits at 15% versus 20%, and if you think like a surgeon, more is always better. But if you think like a physician and what your patient needs, it might be that we don't need the bigger and better drug as we move on. So when we look at that, we'll see that that they're great, they're better than, and David's shown this data. Few serious harm effects with any of these, and there's a suggestion, of course we haven't got the data yet, that liraglutide and semaglutide might have beneficial effects beyond that, particularly cardiovascular outcomes, etc. Phentermine topiramate is the least expensive, and it meets its acceptable cost effectiveness in its combination form. Hey, but it's actually cost saving. There's not much in health that's cost saving when it's prescribed generically as we do in Australia. Now, it doesn't suit everyone, but when you get a good result with these drugs, remember the standard deviation of these drugs, it's enormous. It's the same as surgery. It's the same as, some people, what percentage of people who took semaglutide for 12 months didn't lose any weight? 5%. Okay, 5%. So we've got a standard deviation, and someone who responds beautifully to a cheap drug can do very, very nicely. So it's horses for courses, and I can tell you how many patients I've got with major cardiovascular disease, etc., who are on topiramate, no side effects, no problem, and they would never stop it. It prevents their migraine. So naltrexone bupropion is cost effective, but only when you use it generically. It's cheaper to use generically and mix the two together. And of course, semaglutide's going to have to come down in cost to actually meet any thresholds for cost effectiveness, and this is ISA this week. So when it comes to weight loss medications, the indications are very similar across all of the drugs, 30 plus, BMI 27 plus, and along with, of course, using lifestyle measures. The BMI thresholds are lowered in Asian countries, high-risk individuals, etc. So when we use a drug, there's no point in taking a drug that's not effective. There's no point in taking a drug that has unacceptable side effects and taking one that has a net risk to your future. And many drugs have left the market. But equally, there's no point in stopping an effective drug if it's well tolerated and risks reduce. And I can't tell you how many people came to have bariatric surgery in Australia when sibutramine went off the market. They were suddenly putting on weight. The same when we were using semaglutide in a phase 2 study and had to stop the semaglutide because our patients had lost a tremendous amount of weight. They did very, very well in the phase 2 study, but of course they couldn't continue it. And 3 months on the full dose, that is, remember the step would take quite some time to get up to that. 3 months on the full dose is a sufficient time to know how you're going. So chronic disease management, we combine drugs. We've done it for everything else. We do combine drugs, we combine effective diets, and we combine it, yes, with bariatric metabolic surgery. We will be using all of these tools in patients to treat them well. This is the STEP program that David spoke about, and just to let you know that today it was announced the teen study in the STEP program, very nice results in teenagers. This was at Obesity Week. I just got the message this morning, so that's approved. We can expect that adolescents, and of course we've been waiting to effectively treat adolescents without surgery. There's a big resistance still with surgery. I don't agree with that, but there is a big resistance. Here's the data that David showed earlier for semaglutide. I'm not going to go into any detail. The details are all clear to you, and the amount of weight loss is clear. Here's tirzepatide. And remember, the tirzepatide is a single protein. It just happens to affect both. It's a twin cretin agonist, and what we find is that it's got similar side effects to the GLP-1 receptor agonist. Perhaps less risk of hypoglycemia. However, we've got a very big pipeline, all related to gut hormones. We've already heard about the GLP-1 amylin. There's glucagon. We're seeing long-acting amylin is the one that David mentioned. CCK1, CCK2, PY336, and oxyntomodulin are all being sort of looked at. And what's telling us that what works? It's the gut talking to the brain. Exciting stuff. We're learning. Now, when we use drugs, we've got to look after our patients. when we use very low energy diets. We need to support them, particularly for the first few weeks. When we use these drugs, they've all got side effects which are a real nuisance. They're predictable. We can deal with them, but it needs support. This is the education, the self-management support that we provide our patients. How to use very low energy diets, how to use the drugs, how to stay on them and get the best benefit from them. Now, I don't have to tell you about bariatric metabolic surgery. I don't have to tell you about the Swedish obese subject study and the long-term weight loss, and I don't have to tell you about the mortality from this lovely paper coming from that medical student in Singapore. What I do want to say is that, the health outcomes of bariatric surgery or weight loss of any type are likely to have, we know in surgery with the mortality, diabetes, quality of life, etc., eating disorders, etc. So they're very impressive outcomes. We've got to think of those outcomes when we think about what behaviours we're going to learn to teach our patients. We also see quite extraordinary changes in quality of life following bariatric metabolic surgery, and it's been mirrored now by those results from the major drugs like semaglutide. Our role with patients with surgery, and Alex has brought this up already, is the issues of decreasing intake over a long period of time following surgery and the issues of potential nutritional deficiencies with a very powerful drug, because it will reduce that diet over time. And we do have to just be careful that our diet's not sliding and increasing risk. And of course, we've got to have more data on older people, people with sarcopenia, people with bone issues, etc. Just as considerations, not as much as bariatric metabolic surgery. We have to think about how we keep our patients well as they age. And of course, we've seen ways that we can help that with the dietary advice that we give people with bariatric metabolic surgery. So behavioural changes, they're essential in the management of obesity. But I don't think it's for weight loss generally. It's to support the patient. The changes in diet and physical activity, are they essential? I've told many people that I've never met a surgeon who's had bariatric surgery that's changed their behaviour. They admit they haven't. But they change their food choices because the surgery does it. Semaglutide does it. Drugs that we use have an effect through, they actually work, the hypothalamus has to work through the hedonic areas. They have to work, and it's not our prefrontal cortex that governs choices. It's got to go back, they've got to cope with what they're getting from the homeostatic and hedonic areas, and that's how it'll be expressed. So what we do is, once people have got control, then they can actually change some things to the better. Are healthy diets and physical activity great? You betcha. But the bigger we see our patients, the less faith they have in those. They have almost no faith in those too, because they've tried them over and over again. So we've got to be very careful. And then perhaps once they've got the advantage of a drug or a very low energy diet or surgery that's actually suppressing their symptoms of obesity and they feel in control, that's when they can make food choices, that's when they can exercise more, and that's where you can engage them in that long-term process of managing their disease over many, many years. So it comes down to the obesity is perceived to be a problem that's personal responsibility. Biology tells us something completely different. Yeah. And therapeutic inertia has not been described in the literature with regard to obesity. I can't find a paper because there isn't any. All right? It's not inertia, it's neglect for at least 95% of people. And then when we look at people who use drugs, they use them for a very short time only. Crazy, we don't do anything like that. So therapeutic inertia is not described. What comes to mind when we reflect on the behavioural interventions that we need to make a difference? Don't talk about diet and exercise first, reduce the stigma, and then provide things that will help them over the long term. Engage them, have them interested, have them empowered to make decisions about their own health. Thank you.
Thanks, John. Very wonderful speech. Because of the stress of time, so we're going to our next speaker.
Thank you so much. The next speaker
in there is reflected in the studies that I'm going to show. The barriers and motivations of patients, very important, not just of the patients, but of ourselves. All right, and to generate some insights here. It was mostly an online recruitment. It was all done over the COVID period. Some had to be done in person. In some countries, it was actually translated to the native languages. Now, we use self-reported weights and heights, which is then calculated BMIs, 25 for most countries, except for Singapore, we use 27. Now, physicians there, as you can see, need to have some experience managing patients with obesity. Some of the results are that there were 10,000 over patients that were interviewed. We had a good mix of gender there. As you know, most obesity-related interventions have a predominance of female representation. So we're quite happy that we got a good mixed gender mix. And most people wanted to lose about 23% of the weight. That's a lot, a quarter of their body size. All right, it's a lot to ask for, as if you've heard, compared to the IO, which John had talked about and really been reported since the last 8 to 10 years. It was 16%, right? So we're a bit more unrealistic in this part of the world. I don't know, it's because of the K-pop and all that imaging that's influenced people, but there's some cultural differences here, obviously. Now, in terms of the BMI, majority of patients are in class 1, but again, these are self-reported data. We tend to make ourselves weigh less when we report, and as Asians we tend to make ourselves taller, right? So therefore the BMI will definitely be lower. So this is at best a very modest report. But what's surprising is that 45% of our patients actually think don't have obesity. All right, that's quite a scary perception. Just think about perceptions here of the patients. And in terms of our physicians, we had nearly 2,000 physicians that were interviewed. And sorry, our healthcare professionals in these regions were all doctors. Whereas in other action studies, there were other professions like dietitians, etc. We do see a predominance of male physicians in this study here. Now, the steering committee of which I was part of, we wanted not just endocrinologists. Obviously, endocrinologists should not be the only ones looking after obesity, and surgeons, you represent under the other specialties there, a 40% tucked in there somewhere. All right. So I think I think not surprisingly, I think it's been increasingly recognized as a chronic disease in obesity, though, wish more patients would view that as a problem. But what's surprising is that a quarter of them have not been told by their physicians they have obesity. And 43% have spoken to their doctors in the last 5 years. And in terms of doctors, 40% of them didn't even tell their patients that they had a problem. Now, if you think about chronic disease, if you think about type 2 diabetes, heart disease, hypertension, will you not tell your patients that? So, disease, they're not doing things that are consistent with viewing things as a chronic disease. Right? They do, everybody feels that, yes, it's as serious, or in fact, more serious than diabetes, cancer, and stroke, huge impact in life. But when it came to seeking information, they didn't come to physicians. They trusted the internet, smartphone apps, TikToks, etc., more than, than us. All right. So I think there's some discordance there in terms of healthcare systems. You can see that obviously we've believed in our healthcare teams, but maybe not so much for the patients with obesity. Now, I think there's a lot of talk about, patients, right? So that's where it's reflected at 76%. But actually, patients may not feel that way. All right, so they may be willing to pay for the treatments if they see the benefits, or we tell them the benefits of these medications, but maybe because they didn't know the cost of some of these medications. So I'm not really sure what the real reason is. But in terms of the treatments here, as John has talked about, in Asia, it's quite sad that people don't even talk about diet and exercise, actually. And if you actually go down to what I guess we're quite interested in here, prescription weight loss medication, surgery, it's down at 8 to 11%. And I'm going to zoom in a little bit that when asked about weight loss medications, most people with obesity want to lose weight on their own. They feel that drugs are dangerous. Even physicians feel that way. And they worry about the side effects and maybe about the efficacy and the long-term safety of all the medications that has been presented to you earlier in the last two speakers. Surgery. Now, 2/3 of the patient would rather lose weight on their own, to try and exercise, than to go to surgery, and they worry about the safety of the surgery, and they don't quite believe, if you see the bottom line, that weight loss surgery is actually more effective than other treatment options. And I think likewise for the physicians. This all just reflects, in summary, there's a big gap, right? There's a big gap in what's the science out there, what the science is out there, and what people truly believe, even physicians, and especially patients. And that points like that we have a lot of work to do, and then education is definitely one of them. And perhaps a lot of this lies in terms of the weight bias internalization that patients have. That's why they don't believe in the diets and the exercise. And same likewise for physicians. They've seen patients so-called fail. They don't believe in all these things. And I think, like as John has mentioned, and I truly agree, is that we need to deal with all these. And we often quibble about this versus that, which treatments, but we really miss the elephant in the room. I'm going to switch quickly to the next project, as I only have like really a few minutes. Is this obesity consensus and the care management? This was my hobby for the last 2 years in COVID. While this study was a unrestricted grant from Novo Nordisk, actually the panel that was committed here, we did not receive any honorarium for that. So basically, it was really anchored with the Asia Oceania Association for the Study of Obesity, and it rose from this need. You know, we have all these rapidly advancing treatments, anti-obesity medications, but in some countries, our guidelines are old, and in many countries in this region, actually half of the countries that involved here did not have any national guidelines in terms of obesity treatment and care. So I think it was with this dying and with this really tsunami of obesity coming, we're really unprepared, right? So as a team collectively, we thankfully had the commitment of all these wonderful panels. Now, it can't represent all the countries. A lot of countries are huge here, but we could only manage to get one key opinion leader. And then we had a bariatric surgeon, and we also had a pediatric endocrinologist represented here. And we also had 2 advisors from Australia. Samantha Hawking takes care of, it was the chair of the NACOS in Australia, and she's a lot of experience in that. So we just want to borrow some experience for that. And it was co-chaired by myself and Professor Brian O'Few. And it took us a total of at least 16 months from the time we drafted to that. It's just to reflect the commitment of it. And it's just to let you know, it's been accepted for publication in obesity reviews. But what really guided us was these 12 questions grouped into firstly diagnosis and assessment, 1 to 3, and then goals of treatment, and then moving to modalities of treatment. And last but not least, having to address stigma and cultural differences in this area. Now, again, BMI has been alluded before, I wouldn't say BMI, the risk of BMI is not equal, all right, obviously. And I think it's because as Asians, we just generally pack more fat, and we pack them in the wrong places, and therefore we create a lot of havoc like inflammation and risk for type 2 diabetes. And this is nicely done in the UK, people living in the same environment. For the same BMI that a white person of 30 has for type 2 diabetes, we South Asians develop a much lower BMI, 24, and us Asians at 27, such that at a BMI of 24, Asians have a 6-fold increased risk in 10-year risk of developing diabetes compared to the Caucasian. Now, with that, and piled on that, we also have a lot of cultural differences. This area is seen with rapid economic growth that our phenotype is just not carved up to unfortunately enjoy the luxuries of this modern lifestyle, which is quite toxic. So with that, we took all these into account in our development of the consensus, and especially the diversity of these attitudes. Yesterday was mentioned that, right, a lot of carb-based diet, laborers. Our food was meant to fuel us for the hard labor for the day. Now, comfort food. Food. Now, this is can be a guide, right? And we strongly encourage them. So I will not go into the specifics. Unfortunately, I do not have time. I'm just going to really Speedy Gonzalez through this. But it's just to say that obesity is a disease, right? We are Asians, just because a patient doesn't quite hit that BMI guideline, that waist circumference guideline, but if they have the obesity-related complications, please pay special attention. Don't just say bye-bye, come back, or never come back, right? Because they're going to develop more problems. So obesity is a chronic disease. You can't just let the patients go. You need to reassess. And when you reassess as a chronic disease, oops, I really did flip through really fast. You have to actually look at the roots of obesity, right? The causes that driven them into the state of excess, right? I think, but last but not least, on top of all the recommendations, which I will not now show, is that we said you have to concurrently address stigma, social cultural aspects, the engagement, right? We also recognize that there was a paucity of tools, especially pharmacotherapy. As you can see here, pharmacotherapy is very, very lacking. Healthcare professionals are lacking. We need to then put in money to training healthcare professionals, equip them to get up to speed in such that, including using things like VLCDs and intensive behavioral therapy to support them through this. Now, I think there are surgeons in the room, and I think you'll be very interested to see what we thought about bariatric surgery in these guidelines. So this was actually kind of what we used. I'm sorry this became blurred out, but we said, in your country, please use your country guidelines. Right? Country guidelines are important because epidemiology studies have been studied about health risks of obesity in that country. If you do not have any guidelines, you can refer to the IFSO APC one here, or in patients with diabetes, the DSS2. But main thing is obesity is a chronic disease. Weight regain will happen, right? It's a fact, a natural cause of obesity. So all options, supportive care, pharmacotherapy should be also engaged for weight loss maintenance. So with that, I'd like to end that. I think the journey ahead is long for us. We've started, and it's a multidisciplinary, and we have to start with recognizing the science of obesity, and then creating the environment, tackling with the ecosystem that patients with obesity live with. From educations, I think we really need a lot more formal training in this region, some of which we've tried already in Singapore, and we'll be reaching out to the region soon. And again, engaging people, the stakeholders. It's not just about healthcare. And with that, we do have an open network in Southeast Asia. And the second one we're having soon in a few weeks, and we hope more people in this region can join us. And with that, I'd like to acknowledge my dear colleagues who have worked very hard, and the work I've presented here today, including Mia here in the presence. Thank you for your attention.
Thank you so much, Dr. Tham. And due to the limits of time, we cannot entertain any more questions. But if you do have questions, you can approach the speakers themselves. And for now, we'll be giving them their certificates of appreciation from the IFSO APC.
Yes, for David Cummings. Thank you very much. Oh, yeah.
Sorry.
We'll be.
Oh yeah, there's so much light. John had Thank you.
Thank you very much.
Opo, ay, salamat. Galing. Ang dami kong pictures. Oh, ano.
Thank you.
Check, check. Hey, hey, hello. Check. Hey, check, check. Hey, hey, hey. Check, check. Hey. Check, check. Hey. Check, check. Hey. Hello, hello. Hey.